So let's continue with COPD. There are two forms of COPD. We have emphysema and chronic bronchitis. They are the same COPD, but they're technically two different things. So let's start with emphysema. This here is emphysema, figure 30-7. So this is the change in emphysema. So if you compare the normal lung and the emphysematous lung, the latter is obviously hyperinflated and doesn't necessarily mean it's capable of more gas exchange. The fact is really the surface area for gas exchange is considerably decreased in emphysema. So let's review what happened here. So I mentioned the protease at the start of the class. Protease are enzymes that naturally destroy and eliminate particles. So whatever we were breathing earlier, all the dog poop or any other pollutants, any debris that we happen to inhale, no problem. We have protease which will take care of those. So they'll break them down, destroy them, eliminate them. Everything's good. However, if we are constantly exposing ourselves to irritants, number one irritant is smoking. So whether it's first-hand or second-hand or third-hand smoking, the fact is you are exposed to cigarette smoke. Now, the presence of the smoke will provide a constant trigger for the release, the production and release of protease. So not only will you have a lot of mucus production, but there will also be a lot of protease production. Now, under normal circumstance, yeah, that's good because you're smoking and you have protease anyway to break it down. So it's kind of good that way. However, it will result in an overly active production of protease. Now, it's impossible to be smoking 24 hours a day, right? So you'll eventually stop smoking when you sleep or when you're working or when you're eating. So during these periods that you're not smoking, protease production is not decreased because of the constant production of protease because of the smoking. Therefore, you'll have higher than normal levels of protease. Now, the protease have one job to do. They're released for one purpose, to destroy and eliminate something. So when they run out of pollutants, irritants to destroy and eliminate, what will they now start to destroy and eliminate? Because there's no more cigarette or nicotine to destroy and eliminate. What will it eliminate next?
Healthy cells?
Yeah, alveoli.
The alveoli and your airways will now be broken down. Again, the protease have one job to do. It is to destroy and eliminate particles. So again, if the moment you stop smoking for a while, the protease number is already there. It's already high in number, so they have to do something. They have, they didn't get dressed up for nothing. So they have to do something. That's their job. So it's these protease, again, triggered by the constant cigarette smoking, that causes the damage on the lung. So elastin is necessary for the recoil. So our alveoli inflate and deflate. So they recoil, allowing us to exhale. Now, if they lose elastin, they lose the elasticity. So now these airways start becoming flabby. They lose their elasticity. So are they able to get rid of air? Can they recoil and expel CO2?
No.
No, not anymore. So they become flabby, inelastic, and therefore can collapse. So here they become large and flabby, less area for gas exchange. So this is now a permanent damage. We do not regrow alveoli. Once destroyed, they're gone forever. So now we have inelastic alveolar sacs incapable of eliminating CO2 because they are again flabby, they don't have elastin anymore. So that will cause an increased amount of air trapped in the lungs. That accounts for the hyperinflated appearance of the lung. So you can have a lot of residual volume as a result, meaning a lot of leftover air every time you breathe. So imagine this, you breathe in, right? And there was gas exchange, but then there was CO2 in your alveoli now. You cannot get rid of them. You can only get rid of a little bit. So you have a lot of air left over from the last breath. So if you have old air there from the last breath, can you take in new air?
Not as much.
No, not as much. So therefore, you'll have shortness of breath all the time because you cannot get rid of the last CO2 that you from the last gas exchange. Okay, so this will result in chronically high CO2 levels, a lot of dead space, pretty much, if you look at it that way, meaning you're breathing, but then you're not getting enough oxygen in the process. So that is emphysema. So these patients with emphysema, therefore, will have these symptoms right here. They'll always be in a state of air hunger, like they're always gasping for air. Each breath is now a chore. No, it's because it's not only hard to get air in, it's even harder to get air out because of the flabby alveoli. So that's the story for emphysema. Let's go to bronchitis, chronic bronchitis, that is, because acute bronchitis is not COPD. Acute bronchitis is a acute infection, right? So it doesn't count. So for chronic bronchitis, now this can occur together with emphysema because this is the same thing that causes smoking, caused by smoking. So this is now in the large airway. So chronic bronchitis is in the bronchus. So if you have emphysema in the lungs, you may also have chronic bronchitis at the same time in the large airways. So this is the same protease we were talking about earlier. So the constant irritation caused again by cigarette smoking or whatever else you're smoking, this will trigger a constant inflammation. And with that will be, of course, increased mucus production. And the more active the mucus producing glands become, the larger they become and the larger amount of mucus they will produce. So you have an increase in the number and the size of your mucus secreting glands. So causing large amount of thick mucus that narrows your airway. And of course, this will damage the cilia that are supposed to propel the mucus. But because of the large amount, of course, these cilia will, of course, be damaged because now they're having to propel heavy amounts of mucus. Eventually, they'll be destroyed. And not only that, because you can't bring up the mucus, of course, you'll have more debris and who knows what other organisms are stuck in that mucus. So they get stuck there, they grow, multiply, and then you get frequent infections as a result. So taken together, you have both emphysema and chronic bronchitis possibly occurring at the same time. And it's just a matter of time which parts of the airway they will now affect. Now, there are a few people who have no history of first, second, or third hand smoking that still develop COPD. In these people, they've discovered that they lack alpha-1 antitrypsin. Now, remember protease earlier? Since protease is a naturally occurring enzyme, produced in response to pollutants, right? So let's say we live in the city and we of course are exposed to irritants, and then we'll have protease. But because it's not constant, it's fine. Now something has to be, our body works by negative feedback, right? So something has to be produced in order to stop protease. Meaning, if there was a trigger for the release of protease, there will also be a trigger to stop protease production. And that negative feedback is alpha 1 antitrypsin. This is another enzyme to stop protease. Again, these are all normal enzymes our body produces on a day-to-day basis. Now, they've discovered that for these people who've never smoked a day in their life or have never been exposed to second or third hand smoking, still develop COPD. So what they discovered that in these people, they have alpha 1 antitrypsin deficiency. They don't have the counter enzyme to stop protease. So as a result, they get protease released, but they have nothing to stop protease. And so the same thing happens. So they get lung damage because of excessive protease, but not enough alpha 1 antitrypsin. So in these people, we can't generalize everybody that when you see a COPD patient that, oh, he's a smoker or she's a smoker. Not necessarily, because there are a few again that have this problem of alpha 1 antitrypsin deficiency. So that's the third group of people. Now let's go to signs and symptoms. Before that, let's do complications first. Now, imagine the hyperinflated lung in emphysema. And we have blood vessels in the lung. So if the lungs are hyperinflated, is it easy or hard to circulate blood through the pulmonary tree?
It's hard to do that.
Yeah,
Hard.
right?
Yeah, there will be a lot of resistance because remember, there's a lot of residual air there. So there's a lot of residual volume. The lungs are hyperinflated all the time. So that means the afterload plus which part of the heart pumps blood to the pulmonary circulation? Is it the left or the right?
Left.
Your
Yes.
left or the patient's left?
Right side of the heart pumps it to the.
The right side.
Oh,
The
yes.
right ventricle pumps blood to the pulmonary artery, correct? And the left side receives blood from the pulmonary veins. So it's the right side of the heart that will bear the brunt of the workload in order to circulate blood to the left and right lungs. So that's why they will develop right side heart failure. It's the same right side heart failure we talked about in chapter 35, but because this is caused by a respiratory problem, not caused by not caused by hypertension, not caused by atherosclerosis or coronary heart disease or valve problem. This is caused by a chronic pulmonary disease. So there's a different name for it. They call it cor pulmonale. But basically the damage is still right side heart failure. The management is also just slightly different. So the patient has right side heart failure. Yes, they'll still receive the doables. Okay, they'll receive the digoxin, diuretics, etc. However, you still also need to manage the respiratory problem because that's what caused the heart failure in the first place. Other complications are because of these chronic hypercarbia or chronic high levels of CO2. Patient, of course, will have hypoxemia and acidosis. The signs and symptoms will show compensation. I'll show you later. Because of their inability to recoil, again, they'll have frequent infections, upper respiratory infections. So just like the pneumonia patient, this patient will be, of course, one of our teaching will be annual flu vaccination as well as pneumonia vaccination according to CDC. If you look at chart 30-9, this isn't really different from chart 35-2, so I won't repeat it because it's the same right-sided heart failure. They'll also develop cardiac dysrhythmias. I won't test that yet because that's in chapter 34, but just know that because of heart failure, of course, that will lead to dysrhythmias, particularly atrial fibrillation. All right, signs and symptoms. Now, this is a chronic condition. There is no cure for this, except, of course, a lung transplant. So the patient will just have to live with these changes in their lung. So there's still a way to live with it, different, but of course, we'll have to do what we can. So it'll be a lot of life-changing adjustments to be made here, particularly before when you didn't have to think about breathing. This time you're gonna have to, okay, because breathing will be hard here, especially exhalation. Actually, both. Excuse me. Both inhalation and exhalation will be extremely will be a chore here. But because it's a chronic condition, there will be periods day to day that you'll see symptoms, which are part of the changes. Plus, at the same time, you'll have to watch out for exacerbations or flare-ups. So you need to distinguish what are the patient's symptoms right now. Are they signs of are they expected changes, or are they signs of an exacerbation? So this is the part where you need to make a distinction, because you can't send this patient every day to the hospital. Right? You only send them to the hospital if they're having an exacerbation. So first of all is the breathing. The lung sounds will be, these are the questions you'll be asking the patient. These are the assessments you'll be observing in the patient. What are their lung sounds? So normally there will be some wheezing, so that is expected. They're normally short of breath, especially with activity. You have to check the sputum. Is it clear or white? So clear is good, colored not so good. Anything colorful is not normal, whether it's yellow, green. So what normal sputum looks like should either be clear or at least white. So when you read this, just take a look at because they didn't put it, the problem is they didn't put it in a table or a chart. It would have been great to see what are the expected symptoms and what are the signs of an exacerbation. They didn't do that. The author just put it all over the paragraph and then just made a distinction that, she usually says, like, for example, here, smokers often have a productive cough when they get up in the morning. All right, so this is therefore expected in a patient with COPD. And this is also expected. So many patients sleep in a semi-sitting position, so that's expected. Another is the, right here, let's begin here. So yeah, they'll be in an orthopnic position, so that's expected. This is of course not expected, meaning if this dyspnea becomes severe, meaning they'll now have activity intolerance, meaning they cannot do ADLs anymore, like bathing or going to the bathroom, or general grooming will be pretty bad when they have an exacerbation, because now the dyspnea is severe. So that is, of course, an exacerbation. This changes here, like you see this person looking really red. This is a compensatory response to hypoxia. The kidneys will secrete erythropoietin in response to low circulating hemoglobin No, not really the hemoglobin, the oxygen, sorry. So due to the low levels of oxygen, high levels of CO2, the kidneys sense that and they will secrete erythropoietin. So this is a body's response in order to, if they can't get the oxygen up, maybe if we increase the red blood cells, maybe we can increase oxygen delivery. So the patient will have polycythemia, which is expected. So these patients usually appear red like this, especially emphysema patients. It's also expected. So they'll have a increased anterior posterior diameter of the chest. So the chest size will increase. They'll have what's called a barrel chest. Respiratory rate is higher than normal, but definitely not 40 or 50. Hey, this is not normal. Maybe they'll be at 22, 24, but 40 to 50, definitely that's respiratory distress already. I mean, how long can you keep up like this? Try breathing 10 times every 15 seconds. You see how long you'll last. That's a lot of energy expended there. This is expected. And these are the expected lung sounds: wheezing, although crackles are not usually present. Okay, so this is what I mean by they didn't put it in a table or a chart. So you're gonna have to read it paragraph by paragraph and put it in your notes what the expected signs and symptoms are versus what are the signs of a flare-up or an exacerbation. Here's the barrel chest that I mentioned. So that is now almost a perfect circle around like a barrel instead of a oblong. You know, the anterior. I mean the lateral diameter should be 2 times the anterior posterior. Should be 1:2, not 1:1. Yes, I'm still aware of the exam review. I'll just stop at the signs and symptoms, and we'll continue with the interventions next week. The finger clubbing here, this is chronic, meaning this is expected. Patient, this is a response to chronic hypoxia. The digits, not only the fingers, but also you also see this clubbing in the toes. And not only exclusive to COPD, you'll also see this in any other hypoxic, chronic hypoxic conditions like heart failure. Heart failure patients have poor circulation, so they may also have clubbing as well. And that's it. We'll continue with lab assessment next week. Any question before I